Good morning, everyone. I'm Dr. Shreya Nataraj. Today I'll be speaking on when optic atrophy meets papilledema, a case of Pseudo-Kennedy syndrome. Pseudo-Kennedy syndrome is defined as one-sided optic disc edema and optic atrophy in the other eye, but without the presence of intracranial mass lesion. Whereas Foster-Kennedy syndrome refers to a constellation of findings associated with tumors of the frontal lobe, resulting in optic atrophy in the ipsilateral eye, optic disc edema in the contralateral eye, with associated ipsilateral anosmia. The purpose of this report is to present a case of Pseudo-Kennedy syndrome and to highlight its clinical features and its diagnostic challenges. Methods: a 50-year-old gentleman with a known history of hypertension and diabetes presented with complaints of sudden painless diminution of vision in the right eye for 6 months and some visual disturbances in the left eye for 1 week. There was no positive history of headache, double vision, pain, emotional disturbance, or jaw claudication. Clinical evaluation of visual acuity, color vision testing, autorefraction, anterior and posterior segment examination, and optical coherence tomography imaging was performed. Results: the best corrected visual acuity in the right eye was counting fingers close to face, and left eye was 6/9 with the autorefraction readings of plus 0.5 diopters perical in both eyes. Color vision testing using the Ishihara chart showed 0/15 plates in the right eye and 15/15 plates in the left eye. Anterior segment examination revealed a relative afferent pupillary defect in the right eye and a bristly reactive pupil in the left eye. Dilated fundus examination demonstrated clear media in both eyes with a pale disc suggesting optic atrophy in the right eye and a blurring of disc margins in the left eye suggestive of disc edema with a good foveal reflex noted in both eyes. OCT of the optic disc showed a reduced retinal nerve fiber layer thickness in the right eye and increased thickness in the left eye, correlating with the disc edema. A neurological consultation was obtained and MRI of the brain was performed in which there was absence of any intracranial mass, which confirmed the diagnosis of Pseudo-Kennedy syndrome, most likely due to sequential anterior ischemic optic neuropathy. Blood tests were done for erythrocyte sedimentation rate and C-reactive protein and were within normal limits. Pseudo-Kennedy syndrome is a diagnosis of exclusion with both true and Pseudo-Kennedy syndrome presenting with visual loss with optic disc swelling in one eye and optic disc atrophy in the other eye. So hence neuroimaging plays an important role in differentiating between the two conditions. The most common etiology for Pseudo-Kennedy syndrome is bilateral ischemic sequential anterior ischemic optic neuropathies, either arthritic or non-arthritic. Non-arthritic AION is more common. The pathophysiology is two separate attacks of visual loss with optic disc edema that has resolved to optic atrophy in one eye and a new episode of anterior ischemic optic neuropathy in the other eye. The risk factors are hypertension, diabetes mellitus, high cholesterol, history of smoking, and sleep apnea syndrome. In our case report also the patient had risk factors of hypertension, diabetes, and high cholesterol. Treatment is medical therapy which depends on the etiology. In non-arthritic AION, mainly it is antiplatelet agents like aspirin and cerebral vasodilating agents. To conclude, distinguishing between true and Foster-Kennedy syndrome is critical as their underlying causes and management strategies differ significantly. Accurate ophthalmic evaluation and timely neuroimaging with interdisciplinary collaboration is essential for its accurate diagnosis and effective patient management. These are my references. Thank you.
What do you mean by effective patient management in this case?
If we suspect it is a case of if there's Pseudo-Kennedy syndrome or Foster-Kennedy syndromes, for better management, it's early as possible we should refer to a neurologist and get an MRI done to rule out if there's any frontal lobe tumors or something. So it's better if they go to a neurosurgery consultant and go for it. And if it's any arthritic AION cases, then it's better to start IV methylpred as early as possible.
So in this case, was MRI or neuroimaging done?
Yes, ma'am. Yeah, MRI was done.
What was the risk factor in your patient for non-arthritic AION to happen?
Ma'am, he had risk factors of diabetes, hypertension, and also he also said sleep apnea syndrome, but not confirmed.
Was it uncontrolled diabetes, hypertension?
Uncontrolled diabetes.
Uncontrolled.
Well done.
Thank you.
Please go.